All right. Well, first of all, thanks, Rachel and Amir, for joining. My name is Jake Reese. I'm the Associate Program Manager for MCT2D, which stands for the Michigan Collaborative for Type 2 Diabetes. I'll be going through the majority of the slides here today. And we have Dr. Jennifer Iyengar, one of our clinical content experts in endocrinology for MCT2D here, to field any clinical questions that you guys may have. So I'll handle the operations and she'll handle the clinical stuff. Before we get started, any questions or concerns before we kind of start going through the content that you want to make sure to talk about first? Okay. All right. Well, first of all, thank you so much for joining. This is being recorded, so if there are other folks in your practices that you'd like to share this with, you'll absolutely be able to do that. So this is an informational session for endocrinology participation in MCT2D. So MCT2D is a collaborative quality initiative, and we're going to talk a lot about what that is, what that means, and what your role in the program is. But first of all, I want to call out the fact that MCT2D is multi-specialty. And so we focus heavily on primary care. That's kind of the main hub of the wheel in a lot of what we do. However, we have considerable participation from both endocrinology practices and endocrinologists, as well as nephrology practices and nephrologists. And so a core component of what we do is that interplay between primary care and specialty practices. And so a lot of the focus of what we do in that realm is with regards to referrals and appropriateness of referrals and things like that. So without further ado, we'll start kind of going into some of the meat and potatoes about what this is. So the endocrinology side of the program is led by Kara Mizukami Stout, Dr. Iyengar, and Dr. Lin Ang. And so this is kind of a three-tiered leadership team with each having different expertise, when we're really lucky to have all three of them on board to help guide our quality improvement within the endo side of the collaborative. So for today's agenda, we're going to talk about, like I mentioned, what a CQI is, what MCT2D itself is, how it's different than some other CQIs, and how maybe it's a little bit similar, how endocrinologists can participate, what are the requirements, and what does that look like for you, and then what are the incentives and benefits that you get out of participating in MCT2D. So first of all, what is a collaborative quality initiative? So at their core, CQIs, as I'll now start referring to them, are statewide quality improvement initiatives. They're funded and started by Blue Cross Blue Shield of Michigan. However, we are housed for the most part either within the University of Michigan or Henry Ford. MCT2D is housed operationally within U of M, but we have no real affiliation outside of kind of operationally within U of M, and then funding wise from Blue Cross. All of our work is done as a coordinating center in collaboration with the partners that we have across the state. So as of right now, we have 30 participating physician organizations that encompasses over 350 participating practices, all combining of primary care, endocrinology, and nephrology. The whole idea here is to drive quality improvement using data-backed approaches. So utilizing comprehensive clinical registries where we have integrated both clinical data from the EMRs alongside claims data directly from Blue Cross Blue Shield and BCN. So CQIs really plan and address specific areas and are led by specialists in those areas. So we'll show in a minute here what some of the other CQIs are focused on, and how MCT2D is similar to those and slightly different. So CQIs span physicians, hospitals, health systems, and all of those entities share data back to the collaborative. And that data is what we use to drive quality improvement. And we'll talk a little bit about how the data within MCT2D is slightly different than some of the CQIs, if you've heard of them before, have operationalized data. We are the first population health CQI to launch. And what that means is that we can't really utilize the traditional model of data abstractors sitting at every practice, because we know that there's just too many patients with type 2 diabetes across the state of Michigan where that wouldn't be feasible. A lot of the older CQIs are ambulatory care, episodic care-based CQIs, so surgeries and things like that. And so there's less patients to abstract data for. And so we'll talk a little bit more about what that data flow looks like in just a minute. So how CQIs function is that they are, even though they're funded by Blue Cross, they are all patient, all payer initiatives. And what that means is that the quality improvement that MCT2D or any other CQI dictates that a participating practice or physician organization should be working on in order to earn value-based reimbursement, which we'll talk about what that means in a minute, is for all of their patients, regardless of what their insurance provider is. So the metrics that are set and are worked on for quality improvement are not dictated by the patient's insurance provider. So the quality improvement will benefit a patient that has United Healthcare or Blue Cross or HAP or Medicare or Medicaid, all in the same way. And we want to make sure that that is something that's core to our mission, because we don't want to increase disparities through quality improvement. So the levers of change here, really, as I mentioned on the last slide, is this robust, trusted data, as well as incentivizations for participation, which alleviates some of the bandwidth concerns, allowing practices or physician organizations to have staff to work on these types of projects that they may not otherwise have been able to do, and then change management support. And so outside of the major financial components of CQI, one of our major missions is to provide you as a participant in the program with the tools and resources you need to be successful, both in the quality improvement that the collaborative is working on as a whole, but also in the types of endeavors that you're interested in working on. So we'll talk more about this, but one of our unique features is that we have an entirely integrated design and informatics team. And so oftentimes participating providers will come to us and say, hey, I could really use this type of tool. And I have this idea for this tool. Is that something you guys can provide support for? And that's absolutely something that we do. We have the bandwidth to do that type of thing, as long as it's at least closely related to diabetes. So CQIs do drive change in culture. And so they help drive the way that they help drive changes that providers feel need to occur. And so we have a steering committee and obviously a great board of content experts that help drive and designate the type of work that we're doing. We use data from all of the different participating practices and provider organizations to improve everyone's performance and to help everybody collaborate together. Our goal is not to create a competitive environment. Our goal is to help everybody get better. Rising waters rise all ships. And we also want to make sure that we're developing peer support systems where we're not the ones that are always doing all the talking. We have collaborative-wide and regional meetings where the focus is really around fostering a learning environment where you and your colleagues can sit and talk and problem solve together and learn from each other, not always from us, because we recognize that's not usually how this works. We're not always the authority on this. This is meant to be a collaborative, not a lecture. And then finally, using patient data and feedback directly from patients with type 2 diabetes, with experience caring for patients with type 2 diabetes, to help guide the work that we're doing and making sure that we're staying patient focused, that the tools that we're creating that are meant to be patient facing are accessible for patients and designed with their interests in mind. So this is a list of the current roster, if you will, of the CQIs. On the left here, you'll see the hospital-based CQIs. This is what I was referring to when I mentioned the episodic case-based CQIs. And so a lot of these are surgical-based, so like the anesthesiology, bariatric surgery, knee and hip surgery, and then some other general surgery, spine surgery. And then we have some ambulatory care, some practice-based, and we were the first population health CQI to launch. Closely followed by Inhale, focusing on asthma and COPD. But like I mentioned, this kind of necessitated a shift to a different data system. And so we'll talk a little bit about what that looks like in a bit. But the CQIs on the left primarily use data abstractors sitting at the site manually collecting data on patients of a specific population and sharing that with the CQI. Then the CQIs pay for those individuals. None of that is required for MCTTD. This is all automated through a data flow from the EMR to the Michigan Health Information Network, which is a state entity, to our collaborators here at the University of Michigan called the Michigan Data Collaborative, who aggregates all the data and has all the expertise necessary to ingest millions and millions of rows of data. And I do want to mention that I cannot see the chat because of the presentation screen. So please do unmute and ask any questions that you have. Just jump in at any time. All right. So this is a cool graphic here that talks a little bit about some of the successes that previous CQIs have had and really what they're focused on. So the knee and hip replacement marquee CQI, they've had 32,870 patients avoid a blood clot transfusion that otherwise would have needed one. The anticoagulation CQI, MAQI2, had 100,000 patients not receive unnecessary testing. I won't bore you by reading all of these, but this is a really good graphic that shows just the power of CQIs, what the power of CQIs are, and how they're transforming care. Pause. So they really are a win for everybody. They're a win for patients because they receive better care, as is the goal of quality improvement. They're a win for the providers who provide care because they're afforded the opportunity, both financially and time-wise, to work on quality improvement and continuous improvement. And they're a win for the payers of care too, because they reduce costs through a reduction of either unnecessary care and a lot of surgical-based CQIs, or the implementation of guideline-directed care that is more effective or reduces complications or comorbidities. So with that, what is the paradigm that we're looking to shift with in type 2 diabetes for the Michigan Collaborative for Type 2 Diabetes? So as both of you, I'm sure, are very familiar, the prevalence in Michigan of type 2 diabetes increases at about a rate of 52,000 newly diagnosed patients every year. Approximately 10.2% of adults in Michigan have been diagnosed with diabetes, roughly 165,000, and an additional 240,000 or so Michiganders have diabetes and don't know it. And so obviously, as we all know, it's a population health level epidemic, and we need to make sure that we're providing the appropriate guideline-directed care to these patients. And we know that there's a lot of social determinants of health that play into this as well. And a part of that are the major disparities that we see among individuals who are Black or African American or Hispanic, or among the individuals that have a disability. And so a part of our core mission is to make sure that the quality improvement, as well as the data that we're collecting, is acknowledging that those disparities exist and that we aren't further creating additional disparities or ignoring certain higher risk populations as a part of our work. So as far as what diabetes has kind of always been, is this current standards of care, right? So diabetes runs in my family. It's a risk associated with my genetics. It's hard to change behaviors. It's difficult to stick to diets. So therefore, diabetes really can't be prevented, as well as it's a progressive lifelong disease. It gets worse over time. All I can do is try to manage it as best I can. But really, what we need to be doing is reducing risk of complications and slowing progression. Whereas in this example here, it's really culminating in the idea that diabetes cannot be reversed. And so this is the paradigm that we are looking to change. And so what that looks like is that diabetes is preventable and reversible, that we're shifting towards a culture of healing and repair instead of looking at type 2 diabetes as an insulin deficiency, focusing on newer, more guideline-directed medications for its treatment, and not trying to utilize insulin in a way that accelerates type 2 diabetes or disease states. So our structure here, we have, we're actually at 29 physician organizations. That just recently changed. We have across the state of the entire Lower Peninsula, from the Mackinac Bridge down to Benton Harbor, members that make up over 330 physician practices and over 1,000 participating physicians. Our coordinating center team is a multidisciplinary team that involves primary care doctors, endocrinologists, nephrologists, clinical pharmacists, dietitians, as well as administrative staff, including program directors like myself, as well as a design and informatics team, as I mentioned earlier, who focuses on human-centered design, and really is the core backbone of the tools and resources that we create for the members of the collaborative. So how do we work? What is the core, kind of how do we get from A to B? So MCTTD enrolls physician organizations. There's a total of 40 in the state. And as I mentioned, we have 29 of those right now participating. And then those physician organizations in turn are eligible to enroll their primary care, nephrology, and endocrinology practices that exist under their umbrella. MCTTD has those practices complete a practice change readiness assessment that kind of helps us get an understanding of where those practices are with regards to quality improvement work. What are their experiences with it? What are their comfort level? What are some areas that they may need some assistance with? And then work is guided by a steering committee that is made up of participating physicians across a number of the different participating physician organizations, as well as the patient advisory board that I mentioned earlier. The MCTTD Coordinating Center then provides support and guidance, such as the development of implementation guides for quality improvement, driver diagrams, assistance with developing PDSA cycles, that type of thing, as well as we have over 100 educational resources at this time, and that continues to grow. And we continue to build out additional features and functions, including work right now on a mobile app to make those resources available at your fingertips in the clinic room. We also have robust data reporting systems, including a patient data dashboard that provides insight into a practice or PO's performance on specific quality improvement goals, as well as what we call the patient identification tool in that, which allows practices to search for patients of interest based on clinical criteria such as change in A1C over time, weight gain, whether or not a patient is on insulin, if they've ever used a GLP-1 receptor agonist, for example, or if they are on a CGM, to identify patients that may be good candidates for either more care, like if they haven't been seen in a while, or revised care based on clinical indicators to try to supplement some of the functionalities that may not always be present within a practice's EMR system, especially smaller rural practices. All right, so right now, our current 3 pillars are these right here. So focusing on prescribing of guideline concordant medications. So as I mentioned, that's the kind of the major driver of what we're looking at with regards to supporting the utilization of GLP-1 receptor agonists and SGLT2 inhibitors in a guideline-directed way, utilization of those as frontline therapies, both for glycemic management as well as complication reduction as far as their benefit for cardiorenal complications, supporting lower carbohydrate diets for patients for which that may be a option. The caveat here is that this is not us saying that every patient needs to be on a lower carbohydrate diet. This is saying that this is a modality that can be effective for patients with type 2 diabetes, and taking a patient-centric approach to understand what type of diet may be best for patients, and providing education around lower carbohydrate diets and how it relates to type 2 diabetes to dietitians and care managers to help support patients that may be interested in that modality. And then expanding the utilization of continuous glucose monitors or CGMs in patients with type 2 diabetes. As we know, insurance coverage varies greatly for CGMs for patients with type 2, obviously not nearly as robust as for patients with type 1. So utilizing the resources that we have to advocate for better coverage for CGMs, and to make sure that the education is there for providers that may need it. One win that I'll kind of advertise here is that MCTTD has been gold carded by Blue Cross Blue Shield for any provider participating in MCTTD is now cleared to be able to prescribe a CGM to any patient with type 2 diabetes with no other requirements whatsoever, including no prior authorizations. So kind of going into a little bit more detail here, MCTTD aims to align medication prescribing with guideline-directed care. This includes, like I mentioned, the deprescribing of medications such as insulins or other medications that may place patients at high risk of hypoglycemia, such as sulfonylureas or things like that, and aligning directly with ADA standards of care. So this is not MCTTD coming up with standards of care on their own. This is aligning directly with the latest recommendations of the ADA. It also ensures medication adherence, focusing on patient-centric care, where we're saying, okay, a patient may not always be able to afford one of these medications. That's a common occurrence. What can we do to make sure that the patient is receiving the best care possible? And what does that look like for this patient? And making sure that everything we're doing is not biased by a patient's ability to afford a medication. As far as continuous glucose monitors are concerned, utilizing them in a way that is consistent with how type 2 diabetes really functions and works. So pairing CGMs with diet and education counseling, utilizing CGMs in a way that provides patients the locus of control to understand their diabetes, to understand their glycemia, to understand how the foods they're eating are affecting their blood sugar, and providing that real-time feedback to them. Obviously, there's additional benefits like nighttime hypoglycemia detection, but ideally when paired with appropriate medication prescribing, nighttime hypoglycemia is not much of an issue at that point. And as I mentioned, kind of pairing the CGMs with the use of diet and exercise education. This is just an example here of a patient who had received diet education and had worn a 2-week CGM sensor prior to receiving that and documented their food intake. And so after the 2-week period, you can see the effects of their blood sugar here based on the foods that they consumed on the CGM trend line there. So the third and final of our 3 main pillars is supporting lower carbohydrate diets, really focusing on emphasizing in patients that this is maybe a good choice for emphasizing lower fat, traditional diets have usually emphasized lower fat, higher carbohydrates. They don't necessarily distinguish between slow and fast carbs, and they used fast carbs to manage postprandial crashes. So really utilizing carbs to prevent hypoglycemia, which can result in lows at night and highs during the day. So for patients that this may be right for, the main focus would then be on decreasing carbohydrates to try to stabilize glycemic variability, prevent the lows and highs, decrease hunger and cravings. We know that there can be carb addiction in that sense where patients will crave carbs, and after a long period of time of not having carbs, that cravings goes away. And then decreasing insulin requirements and obviously supporting weight loss. So this is the slide I was referencing earlier. So you can see the tracings before and after a CGM sensor. This patient had no medication change. So this was after a 1-hour session on low carbohydrate diets with a dietitian. And you can see here the patient's time in range significantly increased from the pre-sensor, the before sensor to the post-sensor. And again, this patient had no medication change. However, just a quick note, obviously, for any patient that is starting a low carbohydrate diet, we do obviously recommend decreasing insulin by up to 50% to prevent any kind of hypoglycemia for patients that are already on insulin. All right, so kind of shifting gears now, kind of going into the data and the participation requirements of MCTTD. So how do we receive data and what does that look like? So right now, as I mentioned, diabetes management is really a population level health issue. And so traditionally, as I mentioned, sites will have an abstractor at the site to actually collect the data and send it over to the CQIs. However, that's obviously not feasible. And so we utilize this methodology where we have a statewide data hub where the data is centrally reported to the Michigan Health Information Network, which is a statewide entity. And then that data is passed along to the Michigan Data Collaborative, which is housed within the University of Michigan, which functions as a quality improvement initiative of its own. And that data is then passed along to MCTTD. All of this and the data agreements are handled at the physician organization level. So assuming your physician organization is already participating, all of that has already been handled and nothing that an individual practice would need to worry about. That data is usually sent directly from the EMRs via the data team at your physician organization and would work directly with the physician organization for any issues related to that data transmission. So the important elements that we really focus on as it pertains to the data are what you'd expect really for type 2 diabetes, looking at medications, including SGLT2s, GLPs, insulins, CGM prescribings, other anti-hyperglycemic medications, looking at relevant labs, so A1Cs, lipids, kidney labs, liver, EGFR, urine proteins, anthropometrics, weight, height, blood pressure. And then really in the future, we're going to be focusing on additional data sources, including social determinants of health data, which comes directly from community organizations and from screeners that are done in your clinics that you may already be doing. And then we also obviously collect procedure and diagnosis codes as well as problem lists when available. And continue to build out additional features and functions every quarter. So how do we track progress? So we, like I mentioned, receive information on patients from claims and clinical data. We use this information to create dashboards, and participating in MCTTD gives you access to those dashboards for your practice or physician organization, depending on your access levels. And then we'll show you how you're doing compared to either the collaborative as a whole or others within your physician organization. And you use this information to help providers improve and to reward improvement with the idea of resulting in better care to patients. And so the way that this is done is to utilize what's called value-based reimbursement, or VBR. So we designate a specific performance measure. So right now we have a performance measure for primary care physicians, where they're working on the percent of patients. It's aligned with HEDIS right now, actually, the percent of patients that are above or below 8% A1C for commercial, or 7% for commercial and 8% for Medicare. Or I'm sorry, 8 and 9, 8% for commercial and 9% for Medicare. And then are rewarded based on specific metrics. In the future, we'll have performance-based measures as well for the specialists. Those haven't been designated yet. Just getting started on that. And we'll continue to evolve those performance measures over time with direct input from the members of the collaborative. So this is just a quick look at what the patient data dashboards look like at the moment. So this is our landing page. The patient data dashboard has two main functions, the first of which we call the patient identification tool. This encompasses this tab for the patient list. That's what I mentioned earlier as being an area where you can look for patients of specific metrics of interest that may be eligible or good candidates for additional or different modalities of care. We have the summary measures tab, where this will be more of a standard quality improvement based dashboard that you may be used to from other work that you've done, where you can view your practice or your physician organization's performance on specific measures or metrics that are specific to the work that you're doing in MCTTD. This includes like what percent of my patients have an A1C above or below a certain set point, or what percent of my patients are gaining weight, or show me how many patients I have that are still on insulin or that are on a GLP. A lot of these comparisons can be built, and you can kind of stack different things on top of each other to look at areas that you're specifically interested in. As of right now, the dashboards include primary care doctors, and we just added nephrologists recently, and we will be getting endocrinology attribution in there starting first thing 2025. So as I mentioned, the summary measures page here, this is a current view of just the top of it. It scrolls, but you can see here the performance measure for the A1C control. And then this is the patient profile. This is not PHI, this is a fictional patient. And a lot of this information is available, obviously, in your EMR. It's not like we're trying to replace the EMR. It's meant to be a tool that you can use to identify a patient and then look at some high-level overview of that patient, and then potentially go back to the EMR to determine if further follow-up with that patient may be necessary. All right, so what does endocrinology participation in MCTTD look like? So there are really 5 major components. The administrative side, a lot of which is handled by the PO. That includes the signing of agreements, the data use agreements, and participation agreements. For the actual individual physicians and clinical champions, attendance at regional and collaborative meetings is required, and we'll talk a little bit more about the cadence of that in a minute. Utilization of the data that is shared for quality improvement, and really using it to drive the QI work that's done at the practices, staying engaged, responding to the various surveys and forms that have to be completed, such as the practice change readiness assessment that I mentioned earlier, and then focusing on the quality improvement work, utilizing PDSA cycles and other quality-based modalities to really improve the care at the practice level. So the administrative side here, like I said, signing and returning documents, but a lot of that is handled at the PO level and won't necessarily involve you unless you work at that PO level. At the practice level, you'll need to identify a practice clinical champion. That clinical champion will be responsible for disseminating performance of how that practice is doing, working on the quality improvement, and doing and attending educational sessions and providing education back to the other members of their practice. Additionally, identifying a practice liaison. This is usually a non-physician individual who the MCTTD Coordinating Center will work with closely to help ensure the data quality and completeness, as well as kind of serve as a point person or contact person so that we're not always just communicating with a physician who's in clinic or may not have time to deal with some of those more granular tasks. And then finally, just responding to any inquiries and requests, either from your physician organization or from the MCTTD Coordinating Center. As far as attendance is concerned, we have spring regional meetings that are in person. Those are multidisciplinary. And so we actually have regional meetings twice a year in fall and spring. However, spring is the only time where specialists are required to attend. For fall, it's just primary care. So as an endocrinology participating member, you would just have to go to the spring regional meetings. And then the only other meeting is the Endocrinology Clinical Champions meeting, which is in the fall and is virtual. And so that'll be hosted via Zoom. So only one in-person meeting. The one note on this that I want to make sure that we call out here regarding the regional meetings is that we do have regions across the state. So we have 7 regions broken out by distance all across the Lower Peninsula. And so you'd only be required to go to your region's regional meeting. And so it's not like you would have to drive 6 hours to get to it. We try to limit drive time to no more than an hour. And like I say, it's just once a year. So those meetings really focus on collaboration between the different specialties, between primary care and endocrinology and nephrology. And we really try to make sure that the topics that are covered are really of clinical relevance to you. We put out surveys at the previous regional meeting about what different people would like to see as a focus at the following regional meeting. So again, this is not something that MCTTD as a coordinating center is designating solely. This is done in collaboration with the members. The Clinical Champions meeting, again, this is just one time a year as well, and it is virtual. So this one is going to be a little bit more in-depth and detail-oriented as it relates to endocrinologists. And so we'll be reviewing data and looking at progress on quality initiatives, discussing specific topics that are relevant to endocrinology, learning about results from relevant and late-breaking clinical trials, guideline updates, and then obviously an opportunity to collaborate with colleagues, as is always a focus. As far as data is concerned, for the requirements for participation, a lot of this is handled at the PO level. So there is data sharing requirements associated with participation if you are at the PO level and aren't currently participating. That includes sharing required data elements with the Michigan Health Information Network, as I mentioned, complete additional data fields as necessary. So part of the data that you're submitting is likely for HEDIS reporting purposes, but there may be additional fields that aren't already being sent that could be required to be sent. To share social determinants of health data and allow data to be used in publications, obviously in a de-identified way. MCTTD is currently setting up to handle that, a clinical research committee that'll be made up of members of the collaborative from various different physician organizations from across the state to really help us guide the research or quality improvement, really, publications that are done based on the collaborative. Finally, engagement. So participating in training programs on the MCTTD initiatives, continuing to distribute patient education materials and toolkits to provide to patients as provided by the coordinating center. So like I mentioned, one of the major core functions of the coordinating center is to provide tools and resources to you as a collaborative member. And we want to make sure that those tools are getting into the hands of the patients that need them. And like say, if there are ever any instances where you as a member of the collaborative have an idea for a tool that could be created, that's something that we can take on. We usually just have you kind of scribble it on the back of a white piece of paper and we'll take it from there. That's one of the benefits of participation. As far as quality is concerned, commitment to focusing on the quality improvement initiatives that we're working on, implementing best practices in collaboration with your physician organization, as well as from feedback from the data, and then providing feedback and ideas for innovation, sharing best practices both within your own practice and your PO, but also across POs, really focusing on the fact that this is a collaborative. All right, so incentives for care, or for participation. So as I mentioned, there's value-based reimbursement associated with the participation in the program, obviously the tools and resources, and then the collaboration and community. So starting with the VBR. So the way that this works is obviously as a fee-for-service healthcare model right now, you have 100% of the standard fee schedule. So Blue Cross Blue Shield offers 5% VBR for participation and meeting performance metrics within MCTTD. So just of note, year one in the program is all entirely participation based. So you'd receive that 5% VBR for completing things such as the change readiness assessment and any and all other surveys or kind of administrative tasks that have to be done. After year one, the work really shifts to being performance based, and that'll be kind of guided by the steering committee and the content experts, such as Dr. Iyengar, as far as what that performance measure looks like in years to come. And so, assuming you meet all of the, Dr. Iyengar, did you have something to say? Just so you unmute.
Yeah, I was just gonna can you explain? So like when you say 5% VBR, so basically you get
Yep.
like a 5% uplift
Yep.
on all your type 2 patients with Blue
Yes.
Cross insurance, right?
Correct. So as far as the way that it works is that you have 100% of the fee schedule as normal care. So any and all patients with type 2 diabetes with Blue Cross or with Blue Cross Blue Shield insurance will receive an extra 5% on top of that as far as what they normally would have been paid for that entire population. And so that comes directly from Blue Cross to you.
And that's all patients in the practice, right?
Correct.
Or like
with Blue Cross insurance, yes.
Yeah. And
Yep.
And it's so like you only need one clinical champion, but
Correct.
it's like so the clinical champion is like your representative at that fall meeting. But everyone in the practice can participate, and so then
Correct.
every physician in the practice, their Blue Cross Blue Shield type 2, they get an extra 5%. Okay, just want to make sure because it's like 5% VBR, and I'm like, I just want to make sure that we all know what that
5% for every patient with type 2 diabetes with Blue Cross Blue Shield insurance across the entire practice for participating physicians. Yes. Yep. All right. So this is an example of the requirements from this past year. Next year's are still kind of under review. And so a lot of this will stay the same. Some may change slightly for the first year. So for example, submitting the name of a clinical champion and practice liaison. That's one of the requirements, pretty straightforward. Attending the MCTTD medication and CGM trainings, 1 hour total virtual. Complete the practice change readiness assessment. Attend the in-person spring regional meeting that we talked about. Attend the endocrinology clinical champions meeting that we talked about. Complete a reflective learning on co-management and coordination with primary care offices. Respond to various requests from the coordinating center related to MCTTD work in a timely manner. And then presenting on your sites implementation of quality improvement initiatives, either at a collaborative meeting, regional meeting, or on a conference call if requested. That's usually not everybody and may happen like once every couple of years as we go kind of down the roster.
And I'll just throw in, we're pretty flexible. Like I know that someone, like we're going to have someone present at the meeting and they were like, we're working on like appropriate referrals from primary care, and we have like what we think our referral guidelines are going to be, but it's not like finalized yet. Is it okay? And we're like, you can present what you're working on. So I feel like those are not like high stakes presentations. I think for this upcoming meeting, we had like 2 people that we asked to give like a 10 or 20-minute presentation, and then a few where we just said, can you just give us like a 5-minute discussion to the group about like what you did in terms of your care coordination. So it's pretty it's not like a so a high stakes presentation that you'd be asked to give. So
exactly. Yeah, perfect. Thank you. I appreciate the clarification. All right, so this is just kind of an example, a teaser, if you will, of what our tools and resources look like. So on the left here, you can see this is a patient-facing handout on the benefits of SGLT2 inhibitors. Obviously, as endocrinology specialists, you're well aware of that, but this is something that we've created for you to be able to utilize with your patients who may be considering an SGLT2 inhibitor. And then our dietitian and our dietetics team has created a vast resource library of low carbohydrate diet tools and resources, having identified that as an area where there may be a lack of resources available for patients with type 2 diabetes. This includes shopping lists, cheat sheets as far as what carbs are present in different types of foods, and building your plate type resources. We also have a specific tool focused on insurance coverage, both for medications and continuous glucose monitors. So the tool on the left here is a PDF version of our coverage checker guide. You can see here that this is focusing on GLP-1 receptor agonists for private insurance and pharmacy benefit managers. And you can see the preferred one of the GLPs for each of these insurance providers, as well as what requirements may be present, such as a prior authorization or step therapy. So this is meant to be a cheat sheet to make prescribing of these types of medications a little bit easier, because we know coverage varies drastically and changes all the time, and it's very, very difficult to keep up with that. And so we do that for you. This tool is actually currently being built out into an online resource, and it'll be done in a stepwise flow sheet. So you can say, I would like to prescribe a GLP-1 receptor agonist. This patient has HAP insurance, and it'll provide the results for that, as well as a link directly to the formulary if you want additional details. Other examples here is this medication copay savings card. This talks about the different opportunities that patients have for getting some assistance with affording some of the medications through the actual pharmaceutical manufacturer. So obviously, there's always this component to the collaboration with colleagues. And it may sound cliche, but we do really focus on the collaboration component of the collaborative. We want to make sure that this isn't something that is just work. This is something that you should be getting more out of than you're giving. And a part of that is making sure that we're listening to what you need to be successful, as well as allowing opportunities for you to collaborate with experts from across the state who you may not otherwise have had the opportunity to speak with, collaborate with, or learn from, or help to provide your perspective to. This includes participation on MCTTD panels. We have a learning community event series where different experts volunteer to give an hour talk on a specific area that they're an expert in. This is an opportunity to learn and receive continuing medical education credit, and simultaneously meet a learning community requirement associated with your participation. And so really focusing on that and doing it in a way that really helps you rather than kind of seeming pedantic. All right. I know there was a lot. What questions do you guys have, if any? And Dr. Iyengar, please feel free to jump in and let me know if there's anything else you want to make sure we cover.
All right. Thank you for this. I have a few questions.
Absolutely.
Gonna try to be quick. So first question, I don't know if I misunderstood this, but you said like at the beginning that all patients, regardless of their insurance, can
Yes.
be included.
So yes, the way that this works is there's two aspects of this. The quality improvement from the collaborative is all patient, all payer. So what that means is, let's say right now we have a primary care performance measure. So the performance measure is related to patients that have commercial insurance, what percent are below 8% A1C, and for Medicare, what percent are below 9% A1C. That performance measure, associated quality improvement work, is for all patients, regardless of what their payer is. And the measurement of that is going to be based on all patients, regardless as to what their payer is. Now, for the purposes of compensation for participating in the program, our funder is Blue Cross Blue Shield. And so Blue Cross Blue Shield incentivizes physician organizations and their participating practices based on patients with Blue Cross Blue Shield insurance at that 5% BBR. There's also additional levels of compensation at the physician organization level, and based on the number of participating practices that are enrolled, which is a recruitment bonus. But at the patient level, for the 5% VBR, it's paid out based on the number of the number of patients with type 2 diabetes with Blue Cross Blue Shield insurance.
Okay, thanks for clarifying that. So basically, who decides which patient would be participating or not? Is the practice or the champion? I mean, clinical champion is the one kind of decide, or
patients are not enrolled in the program. Patients are the focus of MCTTD. However, patients are not enrolled in the program. So this is a quality improvement program. That's really what it means by all patient, all payer. So the physician organizations are who MCTTD enrolls, who then in turn enrolls the practices and the practices providers. The quality improvement that's done is across the entirety of the practice, or across the entirety of a physician's patient caseload. It's not saying we're going to enroll this patient but not this patient. It's really all patients within a practice, and the quality improvement is all patient, all payer.
So when you're looking at some quality measures like the A1C, when you said like the 8 or the 9 cutoff,
that's one example.
They're basically, I mean, the PHO is looking, through the EMR, at
Mhm.
that. Is that right?
That's correct. Yep.
Okay. But you're saying for endocrinologists, there's no quality measures as of now.
And there's no participation measure at the moment, no. And for the first year, there won't be. The collaborative is still kind of relatively new. We launched in 2021, and there have not yet been any performance-based measures for specialists. This is our first year with a performance measure for primary care, and we'll continue in the same methodology where the first year of any new participating practice will be all participation-based measures, and then the following year, their second year, or sophomore year, will be a transition over to a performance-based measure.
So,
Okay.
and to clarify, like, so by participation, we mean that you like someone comes to the meeting and you
Yep.
have like the spring
Like
meeting, the fall meeting, and then
Yep.
like, this year the measure was basically like what he had shown, which is like, you have to have like, you basically set a goal of like, oh, I'm going to work with primary care on like, what patients are appropriate for referral and how I'm communicating with primary care. And basically every site got to pick what that looked like for them. So
Yep.
some sites chose like, some sites chose to, for instance, write referral guidelines and say like, we only want primary care to refer us like patients that meet certain guidelines, but it's just like, it's all process, like that you're working on something, that they're giving that 5 or 10 minute presentation. So it's all just basically
Exactly.
that you're showing the effort, is basically what it was for this year. And we haven't decided on like the actual performance-based metric, keeping in mind that like endocrinology tends to have higher A1C. Like we're very cognizant of the fact that endocrinology has higher A1Cs than primary care, right? Because like patients get referred to you because they're uncontrolled. So we need to decide as a group, as a collaborative, and I think that that's something that we're actually hoping to talk about at the fall meeting this year, is to get like input from practices of like what types of metrics do they think would be valuable and helpful. So we're very open to like feedback in terms of what would be like the future performance metrics.
Exactly. Yep.